Harbour, and I want to thank Grant for the opportunity to speak to you today, and I want to welcome all of you who have tuned in. And Grant, I just want to ask, can you hear me clearly?
Yes, we can.
Fantastic. So what I wanted to do today is to kind of cover a broad sweep of what I think is current and important in uveal or ocular melanoma. I'm going to give you a preview into some of the latest research that is coming from our laboratory and from our clinic and from other places as well. Some of this information has not even been published, so I'm going to work in a kind of cartoon format that's easier to understand and doesn't give any exact unpublished data, but I'll give you the important information, and hopefully this information will be published in the medical literature very soon. But I'll be able to give you what's important about the data. So next slide. This is just my disclosure. It says that I invented the gene expression profile technology that I'll be discussing. Next slide. So as I'm sure all of you know, there are good treatments available for treating the ocular melanoma in the eye. In the United States, probably 90% of patients are treated with some type of radiation therapy. We use mostly plaque radiotherapy, as is illustrated here. A few centers use proton beam or other techniques. And there are still cases where enucleation is the appropriate treatment, given the size of the tumor and other considerations. But the point is that, as you can see here from my 16-year experience when I was at Washington University, our local control rate is over 95%. In other words, we can kill the tumor in the eye and keep it from coming back about 95 to 98% of the time. So the problem is not with treating the primary tumor. Next slide. The real problem is with metastasis. And if we follow patients long enough, over 10, 15 years, upwards of about 50% will develop metastatic disease. Now, that doesn't mean that every patient has a 50% risk of metastasis. Some have a very, very low risk, and some have much higher than 50% risk. And that's really what prognostic testing is about, and we'll talk about that later. Now, in terms of metastasis or spread of the tumor, over 90% of the time it involves the liver. And we focus most of our surveillance efforts at the liver because, number one, it's the most commonly involved organ, but number two, it's the most common organ involvement that leads to patient death. So a lot of focus is on the liver, both in the lab, trying to understand why it goes to the liver, and clinically in the clinical care patients to monitor and treat the liver. Now, it's been reported that the survival rates for ocular melanoma have not improved throughout the 20th century, despite improvements in diagnosis and treatment. And I think that those data are true, but they don't capture what's been happening in the last 10 to 15 years with much more intensive research, more intensive treatments, and so forth. So I think that I don't want to walk away from this statement with too pessimistic an attitude, because I think it tells us that metastatic melanoma is a daunting challenge, but it doesn't mean that all hope is lost. We are starting to make real inroads that hopefully will improve survival. Next slide. Next slide, please.
We're on patients who develop metastasis already. Are you seeing it?
I'm ready for the next slide. We're still on the one that says metastasis at the top. Here we go.
Okay, yeah.
All right, so one can think about 3 strategies for improving survival. And first, let's think about, why does metastasis occur if we had successful treatment of the eye tumor? Well, the answer is that the patient who later develops metastatic disease already had microscopic disease at the time their eye tumor was treated, but we couldn't detect it at that time. And that's what's depicted with the little yellow dot, or the little red dot in the liver. Next. Now, let's treat the eye tumor, but we're not aware of the metastatic disease. And so even though we think everything's going well, some number of months or years later, we now have detectable metastasis in the liver. So the simplest strategy next is just to have more effective treatments for metastatic disease. And we know that the treatments we have for treating the liver in particular are going to be more successful if we detect the metastasis earlier. But we need to we need to intensify our surveillance for high-risk patients, but we don't want to subject all patients to high intensity surveillance if they're not at high risk. So a second strategy next is to take those high-risk patients and treat them in an adjuvant or preventative setting to try to delay or prevent those micrometastatic seeds from growing out. And then thirdly, next, a strategy of earlier treatment prior to the development of micrometastatic disease. And I'm going to take each of these strategies in turn. Next. If we look at both strategy number 1 and number 2, treating metastatic disease more effectively and having adjuvant therapy for high-risk patients, both of these rely on knowing which patients are at high risk for harboring micrometastasis. Next. How can we tell if a patient has micrometastasis? Well, so far there's not a blood test where we can just detect the circulating tumor cells with any kind of accuracy that would allow us to use that clinically. We can detect circulating tumor cells from time to time, but it's not accurate enough to be used for this purpose. Next. The most accurate way still of predicting which patient has micrometastatic disease and will later develop metastatic disease is with genetic testing of the primary tumor, of the eye tumor, in some form or fashion. Now, the approach that we have focused on is called gene expression profiling, or GEP, and this looks at a handful of 12 genes that either go up or they go down in the primary tumor in relationship to micrometastasis. And about 60 to 65% of patients, or about 2/3 of patients, will have what we call a class 1 profile, meaning they have a low metastatic risk. And about 1/3 of patients will have a class 2 profile, meaning they have a high metastatic risk. Now, this test was prospectively validated by the Collaborative Ocular Oncology Group, COOG, in a National Cancer Institute-sponsored prospective trial, and it was validated to be very accurate and to be superior to monosomy 3 testing. And it was superior to all other combinations of chromosomal changes and clinical pathologic features. And that's why we have continued to focus on this GEP technology. Next. Another advantage is that this is performed in a CLIA-certified environment by Castle Biosciences. It requires a very, very tiny needle sample, does not require multiple biopsies, which I believe is very dangerous, risking complications. It has a much lower failure rate than other testing methods. Go back, please. And it's easy for the surgeon. It's easy for the surgeon to handle this testing technique. Next. Next slide. So if we look at the first 5 years of using this test, we see that the class 2 patients in red have a much higher rate of metastasis. That line goes down, that slope goes down much faster. But we do see a few metastasis in class 1 patients. And what we've now learned, and this is not yet published, but it is under review. Go back, please. Is that the class 1 patients that do develop metastasis are different than the class 1 patients that develop metastasis are different than class 2 patients. They don't have monosomy 3 or BAP1 mutations. About half of them have SF3B1 mutations. Now, we discovered the SF3B1 mutations and the BAP1 mutations in uveal melanoma here in my laboratory. And initially, we saw that SF3B1 mutations were a good prognostic factor, which they are compared to BAP1 mutations, because BAP1 mutations are almost 100% associated with metastasis. And the two are mutually exclusive. You rarely see a BAP1 mutation and an SF3B1 mutation in the same patient. But if you set aside the patients with a class 2 tumor with BAP1 mutations, then SF3B1 mutations are a relatively poor prognostic factor because they are associated with metastasis later in class 1 patients. The other things we see, class 1 patients who develop metastasis are younger. They tend to live longer with their metastasis, and they're somewhat less prone to liver involvement. So these are really two different sets of patients. Next. So if we go back to this plot that I showed earlier, and this is repeated over and over again in different centers. Next. You see an early, rapid onset of metastatic events in the first 2 to 3 years. Next. But then there's this shallower slope of fewer patients and later metastatic events that occur later. And we believe, next, that many of these patients are going to be these class 1 uveal melanoma patients. Next. So we've really focused on this class 1 group, even though it only represents about 15 to 20% of patients. We know that there is this subset of class 1 patients that have a higher metastatic risk, not as high as class 2, but higher than the rest of the class 1 patients. And initially, just to be able to provide some potentially useful information to patients, a provisional class 1A versus 1B designation was used based on the genes that were already included in the 12-gene assay, the DecisionDx-UM test. But we now have gone back and looked. Go back for me to the beginning of this slide.
I apologize. It's literally automatically advancing, and I don't know why. But
Okay. Yeah. Okay. So we went back and didn't just look at the 12 genes on this assay, but we go forward. We went back and did full gene expression profiling, chromosomal profiling, and re-looked at the class 1 tumors. And first of all, if you're comparing class 1 and class 2 tumors, they're so different from each other that you don't see differences between the class 1s that metastasize and those that don't. But if you take out the class 2 tumors, then you can start to see differences between the class 1 tumors that did metastasize and those that did not. Next. And we found one gene in particular that was greatly, go back for me, greatly overexpressed in those class 1 tumors that metastasized, but not in the ones that didn't. This gene starts with the letter P. We can't publish it yet on the webinar because we haven't published it yet in the scientific literature. But so far, we've looked at 3 independent data sets, and we find the same result, that if the tumor is expressing this marker and it's class 1, that there is an intermediately elevated risk of metastasis. Now, what's really interesting and potentially exciting here is that this gene is immunogenic. It means it is the protein that's expressed by this gene is recognizable by the immune system. So it may be that these patients, we know that in general immunotherapy has not been very successful with uveal melanoma patients, but this may be the subset of patients where immunotherapy is effective. Next. So next. So if we look at the patients that have a class 1 tumor not expressing the P marker, their 5-year rate of metastasis is around 1%, very, very low. If they have the marker, this P marker, it's about 30%. So still much lower than class 2, which is 70%. But this is a group that we will want to pay closer attention to in terms of possible adjuvant therapy that I'll talk about later. Next. So we talk about this first strategy of just better treatment for metastatic disease. And in order to do that, the first thing we have to do is detect the metastatic disease earlier. Now, as I said, only a third of patients have a class 2 tumor, so we don't want to subject 100% of patients to high-intensity surveillance when only a third of them need it. So the prognostic testing, such as the DecisionDx-UM test, allows us to spare 2/3 of the patients intensive surveillance, but it allows us to focus that surveillance on the 1/3 that really need it. So in my practice, I'm currently doing a liver MRI every 4 months for class 2 patients. We detect their metastatic disease earlier, and then the liver-directed therapies are much more effective. Next. That's basically what I just said. The more intensive metastatic surveillance is needed. Now, what are we talking about targeted liver therapies? Well, we can infuse chemotherapy directly into the liver, chemoembolization, or immune therapies, immunoembolization, or little radioactive particles, radioembolization. And I placed at the bottom a reference from Dr. Takami Sato's group at Thomas Jefferson University. And they've really been leaders in this area of liver-directed therapy. And we're definitely making progress in controlling the disease in the liver much more than in the past. Next. Here's a list provided by Dr. Rich Carvajal at Columbia University of some of the liver-directed therapies that are currently available in the form of clinical trials. Next. Next, let's turn our attention to the second strategy of adjuvant therapy. We have a patient who has a class 2 tumor, or maybe a class 1 with this P marker positive, and we don't want to wait until they have metastatic disease. We'd like to try some type of adjuvant therapy to delay or prevent the onset of metastasis. Well, of course, we're going to still rely on this prognostic testing to individualize which patient needs therapy. So a class 2 patient is going to, a rational adjuvant therapy is going to be different than it would be for a class 1 patient with the P marker expression. So next slide. So we start with the mutations. Mutations give us a clue as to what type of targeted drug or targeted therapy is going to be effective. So if we just start with this little roadmap here, we start off with a normal melanocyte that undergoes change into a low-grade tumor. With time, that low-grade tumor can either get larger and become a class 1 melanoma, or it can lose BAP1 mutation, and become a class 2 melanoma. And of course, class 2 melanomas have a higher risk of metastasis. Next slide. So the earliest mutation that we know of that occurs during this process is a mutation in either the GNAQ or the GNA11 gene. This is an activating mutation that activates several growth pathways, and we'll look at that more closely in a minute. Next. Then we discovered in our lab that the mutation that seems to lead to the class 2 high metastatic tumor is the BAP1 or BAP1 mutation. This is a completely different kind of mutation. It's an inactivating mutation that leads to a loss of function of the BAP1 gene and BAP1 protein. This requires a different kind of treatment strategy than for GNAQ, GNA11. Next. And then there are two other major mutations that have so far been described, SF3B1 and EIF1AX. They tend to occur in class 1 melanomas, and they tend to be mutually exclusive with each other. So if you get one of them, you tend not to get the other. And they are mutually exclusive with BAP1, so that each of them is relatively mutually exclusive with each other. Next. Now we can add the class 1 tumors that have the P marker. Next. And this P marker is associated with SF3B1 mutation. So the other newly discovered finding is that SF3B1, even though it's a good prognostic marker compared to a BAP1 mutation, is a marker of increased metastatic risk in a class 1 tumor. So it's associated with this class 1 tumor with the P marker expression. Next. Now, how do we use this information in treating patients? Well, we know that the GNAQ, GNA11 mutations activate certain pathways, and we can use already established targeted therapies to counteract that mutation, such as the MEK inhibitors, MEK inhibitors, such as selumetinib, PI3 kinase inhibitors, PKC inhibitors. These are all in clinical trials, which I will mention later. Next. BAP1 is what we call an epigenetic regulator. It regulates not just one pathway, but it regulates a whole set of genes that are involved in various functions. And so we have drugs that are epigenetic modulators like histone deacetylase inhibitors, HDAC inhibitors, methyltransferase inhibitors that prevent methylation of DNA, and also upregulated in BAP1 mutant class 2 tumors is MET, which is the hepatocyte growth factor receptor. And these are in clinical trials as well. Next. And as I mentioned, we have early evidence that these uncommon class 1 tumors that develop metastatic disease, they so far are all expressing this P marker, which is immunogenic. The immune system can recognize it. So this may be the patients that we want to target with immunotherapy, such as Yervoy, anti-CTLA-4, or with anti-PD-1 antibodies. Next. So just to go a little bit deeper on this, here's the GNAQ, GNA11 mutation, and we know that it activates what we call the MAP kinase pathway. Next. But we now know it activates several other pathways as well. Next. And there are known inhibitors for each of these pathways. So this gives us new rational targets to attempt to control the metastatic disease, or even in an adjuvant setting in patients. And most of these are already in clinical trials, as I'll mention later. Next. Our group showed that histone deacetylase inhibitors can reverse the effects of BAP1 mutations in laboratory conditions. And these HDAC inhibitors are commonly used and widely available. So these are also being tried in clinical trials, both in the adjuvant setting and in the setting of metastatic disease. Next. And this is just some of the clinical trials that are available for adjuvant therapy in high-risk uveal melanoma patients who would have a class 2 tumor. Next. And these are systemic trials for patients with metastatic disease that are using targeted therapies such as I just mentioned. Next. So let's go to this third strategy, the strategy of treating melanomas earlier before they have a chance to micrometastasis. Now, this is potentially the most exciting strategy, but also the most controversial, as we'll see next. First of all, we have to ask, is there any evidence that earlier treatment of a uveal melanoma when they are smaller may improve survival? Well, yes. If you look at the collaborative ocular melanoma study and other large studies, patients with smaller melanomas at the time of their treatment do tend to have better long-term survival. Now, there are other explanations for that, such as what we call lead time bias. Perhaps those with a smaller tumor, you're going to have to follow them longer to see if they're going to develop metastatic disease. And that is certainly a confounding factor. But we have additional genetic evidence that this may be true as well, that smaller tumors may be less likely to have micrometastasized. Next. If you look at my practice, for example, since the early 2000s, in the beginning, when we started doing prognostic molecular testing, I only biopsied large tumors. As time went on and the testing became better and the biopsy techniques became perfected, I have over time biopsied smaller and smaller tumors. You can see now in the current era, I frequently biopsy tumors less than 2 millimeters thick. When we initially started doing molecular prognostic testing back in the early 2000s, a patient with a class 2 tumor, it didn't really matter how large the tumor was, the prognosis was the same. But all the tumors were relatively large. Now what happens when we look at smaller and smaller tumors? Next. Again, this is earlier data from larger tumors that were greater than a diameter of 12 millimeters, let's say. About 11% of the class 1s and about 69 or 70% of the class 2s develop metastatic disease within 5 years. Next. Now, however, if you look at these smaller tumors, only 3% of the class 1 tumors under 12 millimeters in diameter develop metastatic disease at 5 years. And look at class 2s here. Next. Only 12%. So we go from almost 70% down to 12 to 15%, let's say, that develop metastatic disease within 5 years. Now that's pretty interesting, that you can have a class 2 tumor, which we know is high risk, but if we catch it when it's only 12 millimeters or smaller, the metastatic rate goes down. Next. So this suggests but does not prove that earlier treatment of uveal melanomas when they are small, even if they're class 2, may improve survival. Now, before we run off and start treating every small nevus, we need to think through this a little bit more. Number one, there is this issue with lead time bias. We need to follow these patients longer to make sure that they're not going to end up with a similar rate of metastasis, but just at a longer time point. Secondly, using diameter to make clinical decisions is problematic. Number one, a measurement of 12 millimeters by one observer may not be the same the next time that same observer measures the diameter. One time it may be 11.9, the next time it's 12.1. Is that really different? No, probably not. So these are somewhat arbitrary cutoffs. And the differences are even greater between observers. So 12 millimeter diameter in my center may not be exactly the same in another center. We can try to standardize this with ultrasound and photos and things like that, but it's very difficult. I much prefer using genetic molecular biomarkers whenever possible because they're much more accurate. Next. Another even more daunting problem with trying to treat smaller uveal melanomas is that the smaller the tumor gets, either in thickness or in height, the more likely that small melanoma that you're going to treat is actually a benign nevus. Yes, we have clinical features that we can look at to help us predict if a given small tumor is a melanoma or a nevus, if it has subretinal fluid, if it has orange pigment, other features that we can look at. But none of these is diagnostic. We cannot know 100% sure if any small melanocytic uveal tumor is a melanoma or not just by looking at clinical features. So there's always a chance that we're actually treating a tumor that's a nevus and not a melanoma. And when we biopsy and when we treat small tumors in the eye, there's a chance of complication. So we have to take that in mind. Next. And when you look at the numbers here, I conservatively estimated that small melanomas and high-risk choroidal nevi, they're roughly maybe 8,000 in the United States each year. But look at how many overall nevi there are, something like 4 million. So trying to find the 8,000 among 4 million nevi is going to be very difficult just using our clinical criteria. So we really need, next slide please. We can biopsy these, but again, when you get to small tumors, and many of these are close to the fovea, close to the center of vision, we're gonna risk losing vision, causing visual problems in a lot of patients if we just started trying to biopsy hundreds of thousands of these things. And I think the bottom line is we just don't have the technology yet to know for sure if we're dealing with a melanoma when they're very small. And so this is going to continue to require a careful discussion with your ocular oncologist about the risk and benefits of continued observation versus prompt treatment of these small tumors. Next. So in summary, we have 3 basic strategies that we can use to improve survival. We can identify metastatic disease earlier and have more effective liver-directed and targeted molecular therapies. We can identify high-risk patients before they develop metastatic disease and test various agents that have a good rationale as an adjuvant therapy, and to put patients on clinical trials to determine if any of these are effective. And then finally, the idea of early detection and treatment. There's definitely a trend in the field towards treating tumors when they're smaller if they have high-risk features, but we still need to have a careful and frank discussion with patients that they understand that we can't know 100% sure if a small tumor is really a melanoma until it grows. Next. So the individualized metastatic surveillance that we can do when we have molecular prognostic information is very powerful. When a patient is class 1, but they have no expression of this P marker, I only would recommend ultrasound of the liver once a year. If they are expressing this P marker, I would do ultrasound twice a year and potentially treat this patient with immunotherapy in an adjuvant setting. A class 2 patient, I would recommend an MRI or CT of the liver every 4 months. An ultrasound is okay if that's all their insurance company will pay for, but I prefer a liver MRI. And I do encourage these patients to enter an adjuvant therapy trial. Now, many of these trials are, they require entry within 1 or 2 months after diagnosis. So these decisions have to be made fairly quickly. Now, I will hasten to add, I put an asterisk after these entries here because this marker has not been, in my opinion, adequately validated. Now, it's already been validated more than any other testing techniques that are done elsewhere. It's already been validated in 3 independent data sets. However, I'm preparing to perform a multi-center prospective validation with centers around the country, and I would consider these recommendations here preliminary until we have a multi-center validation. Next. So in conclusion of gene expression profiling, in my opinion, gene expression profiling is still the most accurate method for predicting the risk of metastasis from the primary tumor. We anticipate that the new P marker will be included in the gene expression profile as a marker of intermediate risk in class 1 tumor patients. Next. BAP1 mutations are the second most accurate predictor of metastasis after gene expression profiling. These mutations are very strongly correlated with the class 2 profile, and they provide information that could guide targeted therapy with an epigenetic agent. SF3B1 mutations are relatively good prognostic markers compared to having a class 2 BAP1 mutant tumor. However, we did find them in about 50% of the class 1 tumors that metastasize, so it's a relatively poor prognostic marker in class 1 tumors, and more research is needed to understand how best to use this information. Now, interestingly, the other mutation that was mentioned, EIF1AX, is rarely associated with metastasis at all, so this may be a good marker for good prognosis. Now, this is still very much, I believe, at the research level. I do not believe people should be using these mutations to guide clinical care because these have not been prospectively validated, but they are definitely providing important new information. And certainly the presence of a BAP1 mutation or a GNAQ, GNA11 mutation can be used to select a targeted therapy. Next. As we found, tumor diameter below a certain level, around 12 millimeter diameter, seems to suggest a better prognosis, whether you have a class 1 or a class 2 tumor. It seems that perhaps around this diameter is when the tumors start becoming able to successfully micrometastasis, and if we can treat them at or below that size, the chance of it having micrometastasis seems to go down. And again, more research is needed in this interesting area. Next. And finally, I want to encourage you all. Cancer research is like a long war campaign with beachheads. You get the beachhead, then you make a small advance, then you consolidate and you try to learn something and then maybe make another small advance. We're not likely to see a clinical trial that discovers a magic bullet that cures uveal melanoma in one fell swoop. We learn something from every clinical trial, at least the ones that are well designed. Even if the treatment that it's analyzing doesn't provide much benefit, we can learn other things from that clinical trial. So it's important to remember that we're in a clinical trial, we're asking if a treatment is effective or not, but we can also ask other things. Well, that small percent of patients that did respond, what was it that was different about those patients? Is there a biomarker that those patients had that we can use to identify other patients that would benefit from that treatment? And what combination of therapies may work better together than alone? So something useful comes out of every well-designed clinical trial. So I would encourage you to participate and to encourage your acquaintances in this area to participate. Next. So finally, at Bascom Palmer, we are initiating two national multi-center clinical trials in the very near future. One will be to prospectively validate the new P marker and other new biomarkers that we've recently discovered. And you can check with your ocular oncologist to find out if they're one of the participating centers. We have over 20 participating centers at this time from around the country. And secondly, we are starting we're in the planning stages now of a multi-center interventional trial that will look at the immunotherapy PD-1 inhibitor and looking for biomarkers to determine which ocular melanoma patients are most likely to respond, with the idea that this new P marker may be such a marker for patients who are likely to benefit from immunotherapy. And you see at the bottom the phone number for my nurse, Barbara Perez, and the contact information email is to my research manager if you would like to get in touch with us with further questions. Next. Finally, I just want to acknowledge my sources of funding, including the Ocular Melanoma Foundation, which generously has supported our work. I want to acknowledge my collaborators and some of the research team on the right-hand side of the slide. Next. Next slide. Whoops. That slide took me a long time to make. Put that back up. Okay. So, yeah, we're done with the acknowledgement. I just wanted to go to the thank you slide.
Yeah, perfect.
One more slide. There you go. Thank you. So I want to thank you for your attention. And Grant, I think that we have time to answer some questions if there are any from the listeners.
Sure, and we'll move over to that in just 1 second. I just wanted to make sure that everyone was okay. We've had a few technical glitches. Apologies for the advancing of the slides. That's a hiccup with the AnyMeeting system. And for those of you who emailed me during the webinar about the intermittent audio, for the Q&A session, you would be recommended to dial into a landline, and you'll probably have better luck there. But apologies for any of the technical hiccups. So we have about 75 people on the webinar, so unfortunately I won't be able to unmute everyone. It would create too much background noise. If you have questions that pop up, please send them to us over chat, or you can email me at webinar@ocularmelanoma.org. But we did want to start now with a question about taking a genetic test. One individual writes in, I took a genetic test 4 years ago and found that I was in a high-risk category. Is there any point in being retested?
Well, it depends on, there are a lot of factors there. It depends on the quality of the testing that was done. If it was a good, reliable test, then I don't think that would need to be redone. Most of the tests of the primary tumor are not reliable after radiation, certainly not 4 years after radiation, where it's mostly scar tissue left. But I would also say that the risk of metastasis seems to peak at about 2 to 3 years after treatment of the primary tumor, and then it slowly decreases and flattens out. The risk never quite gets to zero, but after about 5 years, the risk is quite low. So, we generally, you can't guarantee that there won't be metastasis after 5 years, because certainly there can be rare events, even decades later. But the vast majority of metastases are going to happen within the first 5 years. So if the person is 4 years out, they're almost at that point now.
Interesting. Next question. Once the P marker is published, can Castle Biosciences pull old samples and test them?
Yes. And in fact, the centers that are part of the multi-center trial, if they have any sample left, they can send that in as well. So any, Castle on a individual basis, depending on if it's been requested and consented, can save extra sample from patients. But but in other situations, if the ocular oncologist still has sample, that can be sent in to be tested as well.
And as a follow-up question, someone else asked, would they then qualify for adjuvant treatment? So I'm assuming the question really gets at, would it be worth them going and having another conversation with their oncologist?
Yes. I mean, I think at this point, we have to, I hold a very high bar for myself in terms of validation. So even though we've already looked at this in 4 independent data sets, I would like to see this in a prospective multi-center study. But I think that on a case-by-case basis, that once this information is published, it's been peer-reviewed, published, then the patient can have a conversation with their medical oncologist on a case-by-case basis about the suitability for immunotherapy, yes.
And what are your recommendations for patients who were treated but did not have biopsy at all?
At this point, if they had their eye removed, if there was an enucleation, then you can go back to that tissue and it can still undergo the gene expression profile test. If they did not have the eye removed, but it was radiated, which is usually the situation, I think the best you can do is go back to the original features of the tumor, the size of it, whether it was involving the ciliary body, and make an estimate of whether they were in a high-risk group or not. And when I have a patient in that situation, I tend to err on the side of assuming it was a higher risk tumor and just monitoring, doing the metastatic surveillance a little more frequently than I would, for a low-risk patient.
Fantastic. Can you update everyone on the current thinking related to 1A versus 1B classifications? Why has this data not been published since Class 1 was split?
Yes, this will be published with the P marker. This was a provisional designation based on the cohort from the Collaborative Ocular Oncology group to identify patients who are potentially in this intermediate risk group. Because there are so few Class 1 patients that develop metastatic disease, I've only had 12 since we started doing the testing. It's been difficult to get enough samples to do statistically meaningful analysis. So it's taken a while to actually compare the 1A, 1B to this new marker. And at least in the cohorts that we've looked at, the P marker is, we believe, going to be more accurate than the current 1A, 1B. But both of those will be available. But we believe that with the prospective validation, that my hypothesis is that the P marker will be more accurate than the 1A versus 1B.
What is your opinion on second-generation tissue testing? And we've actually had 3 follow-up questions surrounding second-generation testing and just general thoughts on it and how effective it is for predicting.
Second-generation. Say that again.
Tissue
second-generation.
Doing foundation or any of the other full second-generation tests, I believe, is what people are asking about.
Yeah, for ocular melanoma, they're not really that helpful, to be honest, because, ocular or uveal melanoma is a little bit different than most other cancers in that there are very few and very discrete mutations that occur in uveal melanoma. I just mentioned them. There will be a few more, but they will be relatively rare. And I think that for the foreseeable future, our decision-making is going to be driven mostly by these 5 genes that I mentioned today. Now, there may be an exception. There could be a very atypical or odd case, and maybe none of these mutations are present. And yeah, in that situation, getting a broad mutation panel may be appropriate. But I think for the average patient with ocular melanoma, it's not really going to provide you additional information, useful information over having the information on these mutations. And for example, Castle Biosciences is going to start having the mutation status available for GNAQ, GNA11, as well as some of these others, I believe. So, I think if you have the 5-gene mutation panel, that's really sufficient in most cases.
Okay. Next question. I saw you suggested that patients might want to take valproic acid off-label. This was from an interview a couple of years ago. Do you still feel that might be helpful? If so, for how long might it be beneficial, assuming the patients are tolerating it well? And is there a cutoff time beyond which valproic is unlikely to do any good?
So, this is the reason that I prefer clinical trials. And, we have more clinical trials, like I mentioned several there in the presentation, because we don't really know the answer to those questions. We don't know how much you need, how long you need it, what the dosing schedule should be, et cetera. And so that's how we gain that information. Even if it's negative information, we can say, okay, well, that dose didn't work. We need to try a higher dose. But that's why I think that it's important to do these within a clinical trial, if at all possible. And in the talk today, there were trials available that are using HDAC inhibitors such as valproic acid. So I would recommend going in that direction.
Are there any other off-label medications that might lessen the risk of metastasis even a little? What about aspirin? What about melatonin? Other changes you might recommend? Or is this still getting back to further clinical trials need to be done?
Yeah, what I tell my patients is that there's none of these off-label things certainly have any proven benefit. The one thing I think would all agree on, or most experts would agree on, is that your immune system plays an important role. So the more that you can have a healthy lifestyle, a healthy diet, exercise, these sorts of things, I think these all help. But I think these off-label, agents that are purported to fight cancer and so forth, most of these are really unproven, and I don't recommend them.
Switching gears a bit, are you concerned about new studies suggesting that MRI contrast, Ivosist, and other variants of gadolinium is leaving deposits in the brain that build up over time?
I'm not aware of that being a problem. It's not something that I have confronted. If there is a concern about that in terms of getting the liver MRIs, the ultrasound is pretty good. Ultrasound is just for surveillance. I have patients that they're claustrophobic, or they just don't want having the dye, or they're allergic to the gadolinium dye, or what have you. It's not unreasonable to just do surveillance with ultrasound.
Another question around, are you aware of patients with cutaneous melanoma from malignant blue nevus or otherwise that express GNAQ and or BAP1 mutations and have metastases to the liver? If so, do these patients have a different prognosis from traditional metastatic patients?
Okay, well, there's a lot wrapped up in that. First of all, there will be rare exceptions to this statement, but in general, GNAQ, GNA11 mutations are seen in ocular or uveal melanoma and in central nervous system melanocytomas, a kind of benign variant of melanoma. But cutaneous melanomas rarely, if ever, have GNAQ mutations. I'm sure there will be one out there somewhere, but it's extraordinarily rare. We don't think of GNAQ, GNA11 mutations in cutaneous melanoma. BAP1 mutations can be seen in cutaneous melanoma. They're not nearly as common as they are in uveal melanoma, but they can be seen, and they tend to be associated with more epithelioid morphology or shape of the cells. And I'm not sure if there's really been enough patients with cutaneous melanoma with BAP1 mutations to know whether it really increases their metastatic risk. When the first paper came out on cutaneous melanoma and BAP1 mutations, I asked the authors about this, and they said they had not seen an increase in metastasis, but there's only a small handful of patients. I think what's important to recognize is that there is a hereditary BAP1 cancer syndrome where you inherit a mutant copy of BAP1. And those patients are at risk for both ocular uveal melanoma as well as cutaneous melanoma, mesothelioma, kidney cancers, and other cancers as well. So in that setting, those patients, I tend to treat them more aggressively if they have a small choroidal melanoma / suspicious nevus. I'm going to be more aggressive with them because they already have a BAP1 mutation. So they're going to have a higher risk of metastasis than the average patient with a small choroidal melanoma.
And what would be the best way to detect that germline BAP1 mutation?
That can be detected with sequencing from the blood. There are, Castle Biosciences provides that service as well from a blood sample. I think other labs may be doing that as well. It's not trivial to sequence this gene because you're not just looking at one small part of the gene and saying, is there a wrong sequence here? You have to look at the entire gene, which is a very large gene, because an inactivating mutation can occur anywhere. Anything that fouls up the sequence of the gene can be a mutation in that setting. So it has to be a laboratory that's experienced with sequencing large genes.
And one question just came in: is it worthwhile to do germline testing for BAP1 in a quote-unquote sporadic case? Not quite sure what that sporadic means, but
the criteria that I use for recommending germline BAP1 testing is number one, if the patient is young, let's say under roughly 30 years old. That's a little unusual, not unheard of, but when you have a germline predisposition, you tend to get cancer at a younger age. So number one, if the patient's young. Number two, if the patient themselves or a first-degree relative has a history of uveal melanoma, renal cell cancer, kidney cancer, mesothelioma, or cutaneous melanoma. And most of those are going to come back negative. Germline BAP1 mutations are only present in maybe 2% of uveal melanoma patients. But if I see a strong personal or family history of cancers, particularly of those cancers, then I would recommend germline testing.
Fantastic. One more broad question came in. Knowing nothing else, what steps would you recommend to a Class 1B patient after 4 years with no mets?
After about 5 years, I have a conversation with the patient and I draw the curve, where most of the metastases overall occur in the first 5 years. But as I showed in the presentation today, that smaller group of Class 1 patients who are at intermediate risk, that for now are best indicated by the 1B designation, they may be at risk for later metastases. So I have this discussion with them. I tell them that their risk is relatively low. If they've made it 4 or 5 years out, their risk is decreasing, but it's not zero. And some patients really want to stay on top of this, and in that setting, I recommend continuing with an ultrasound of the liver or an MRI of the liver. But I think unless the patient is very obese, if they're not terribly obese, then an ultrasound of the liver once or twice a year beyond that 5-year point is what I usually recommend.
Great. Next question. How should we think about overlap of type 1, meaning P+, versus current type 1 AB classes? For example, is there a high overlap between type 1B and type 1 P+?
There's some overlap, but there are definitely cases that don't overlap. So that's what we'll be looking at prospectively. But the overlap is not great enough that we could just substitute the 1A, 1B for the P marker. I think the P marker will eventually replace the 1A, 1B, but we want to formally compare them to know that answer correctly. But a patient who has a 1B tumor, it's possible that it might not be expressing the P marker. They may actually have a better prognosis than they think. But I prefer to assume the worst. In other words, I would continue with the 1B surveillance, which for me is twice a year ultrasound until proven otherwise.
Okay. 2 questions have come in about metformin. Any chance metformin off-label or aspirin might help prevent class 2 metastasis? My tumor is 12.43 basal diameter. Is there a steep rate of increase above 12 millimeters or a steady gradual one? So part of this was already answered by your commentary on the need for more information, but do you have any comments on metformin specifically?
Yeah, I can't give you a recommendation on metformin specifically. There's not enough data out there to make any conclusion about it. So I can't really tell you anything more than that. In terms of the diameter, that's a very good question. Is it a sharp inflection point, or is it a gradual change? There seems to be an inflection point around 12 millimeters, and then the risk does seem to increase thereafter with increasing diameter. Now, I want to hasten to add, to repeat what I said earlier, that my measurement of 12 millimeters may be the same as your measurement of 12.4 millimeters taken by somebody else. So this is just a general guideline. I don't think we can use diameter measurements or thickness measurements we can't rely too much on them because they're too variable. So 12.4 is relatively small, so that's good. It's better than being 13. It's better than being 15. But is 12.4 worse than being 12.1? Probably not. But so I think we have to take these clinical measurements with a grain of salt, and that's why I really have tried to focus on molecular prognostic markers, which are accurate, very, very accurate measurements, rather than these very inaccurate clinical markers. But I think that the main point is that somewhere around 12 millimeters or so, the risk starts to go up. But I think 12.4 is still relatively small.
One question around the clinical trial you mentioned. Will that be at UCLA, to your knowledge?
I would have to go back and check the list, but you could ask your ocular oncologist there.
Okay. Well, are there any more questions for Dr. Harbour that you can send via the chat function? There are a couple that came in about very specific cases, and I decided to hold off on asking those. Perhaps an email to Dr. Harbour would be more appropriate. Some of them were very detailed. But
okay.
I just don't want anybody to think that their questions weren't answered. But I think we're coming up on our time. This has been fantastic, very educational for me. Again, Dr. Harbour is a leading expert, globally recognized in uveal melanoma research. This might have been too much detail for some of you, but I encourage you, to follow up with your ophthalmologist and oncologist directly to continue to ask questions. You can review this later online, but it's very clear that there are some very important breakthroughs happening in uveal melanoma, and I'm personally very excited to see the pace at which those are coming out. And then Dr. Harbour, through his 16 years at WashU and now his time at Miami University, is truly a vanguard in doing that. So, Dr. Harbour, thank you for joining us today. This has been fantastically educational.